and welcome to this multidisciplinary endocrine symposium. My name is James Ahlquist. I'm a clinical endocrinologist, and with my colleague and friend Tricia Tan, we'll be chairing the first section of today's meeting. It's great to see you. Look around you and you will find 45 ghosts beside you. And they are our friends online who have also logged in from afar, because this meeting is unmissable. So thanks to IT, we've made the unmissable unmissable, and they will be joining us. So colleagues off-site who are online, do join in with the discussion. One of the key features of this meeting is interaction. That's a nice way of saying argument, dispute, discussion, debate, and we would love to have, this microphone will be working hard. 2 magic ingredients for this meeting: fantastic speakers who are real experts, and you who add the leaven to the mix and make the meeting really work. So our friends who are not in the building, but are keying in from afar, please use the chat box. We're monitoring the chat box, and we will voice your questions and your comments and your disagreements and your debates. We are very keen to have you fully involved with the meeting. We begin with obesity, and Tricia will introduce.
Hi, so our first speaker probably doesn't need much introduction. It's Professor John Wilding from the University of Liverpool. Most of you know John has led sort of multiple clinical research in drug development, the big GLP-1 trials, and he's here today to tell us about the new drugs and mechanisms of treatment of obesity. Thank you, John.
Great, thanks Tricia, and good morning everybody, and good morning to all of those that are listening online. So I've got about 25 minutes now. I want to allow a bit of time for discussion to talk a little bit about some of the new drugs that are available and what might be coming along in the future to help support and treat people living with obesity. Make this forward. Do the first test for me. Okay, we'll go this way. Just to set the scene a little bit, because this is the first talk of the morning, and I know we're going to be talking about obesity quite a lot. I want to emphasize the fact that I think we do now need to consider obesity as a disease. It's considered a disease by our Royal College of Physicians, by the WHO, and by a number of other organizations around the world. It's very common. It's increasing pretty much everywhere in the world. The reason why it's important to us as doctors is because it increases the risk of multiple other diseases. So it has its own sort of set of complications, much as the way as a disease like diabetes has complications. That means it's very expensive to healthcare systems, largely as a result of the cost of the complications. And although we've learned a lot about the underlying biology, which is largely important for the susceptibility of individuals to obesity, genetics, epigenetics, and so on. The reason why obesity has become so much more common over the last 30 or 40 years is because of environmental changes in our society. And that's just the same as many of the other diseases that we treat. And we can think of diabetes, cardiovascular disease, cancers, etc., all of which have this combination of genetic and environmental components. So I think that's an important thing. And yet obesity is treated very differently, because it tends to be that we blame the individual, we stigmatize individuals with obesity, we think it's all their fault, and that is wrong. We need to stop doing that. I think I've already highlighted the number of conditions that are associated with obesity and caused by obesity. And one way of thinking about these is the mechanical, metabolic, and mental health complications of obesity. And of course, this has been highlighted very recently by the COVID pandemic. And the fact that people with obesity are much more likely to catch COVID-19, be admitted to hospital with COVID-19, and die from it. And that is, again, really highlight the importance of this as a medical problem. Okay, so if we accept that obesity is a disease and that it has complications, then maybe the right thing to do is to help people lose weight. So how much weight do we need to lose to prevent complications? And of course, that depends on which complication you're looking at. It depends on the natural history of those complications. And if you like, one way of thinking about that is it's the cumulative time over, the area under the curve, if you like, of body size or metabolic complications over the time. But nevertheless, I think it's important that we recognize that we may not need to lose that much weight to, say, prevent diabetes, where we know from the diabetes prevention trials that 3 or 4% of weight loss is actually enough to reduce diabetes progression in people with impaired glucose regulation over 4 to 6 years. And likewise, we can modify conditions like hypertension, we can affect dyslipidemia with that sort of weight loss. Once we start moving into the mechanical complications, we probably need at least sort of 5 to 10% weight loss, maybe a little bit more. And for some of the, if we're going to talk about putting diabetes into remission or preventing cardiovascular disease, we may be looking at requiring 15% weight loss or even more, because as the more weight loss you achieve, the less the outcomes, the less the adverse outcomes seem to be. So what are our goals and benefits if we're going to effectively help people to manage their weight? The first part, of course, is to achieve weight loss, and that usually has to be through energy restriction, and we can have a discussion, if you like, about the benefits of physical activity. On its own, it doesn't help very much for weight loss, but it's important as an adjunct for weight maintenance. And that's really the hardest part, which is helping people maintain weight that they've lost over time, because we know, and I'll show you some data that supports this from multiple trials, if you lose weight through diet and exercise, lifestyle measures, behavioral change, very low energy diets, whatever diet you choose to have, most people over time will regain that weight. And the hard bit is to keep that weight off over time, because that's the only way that we're really going to provide the clinically meaningful benefits that I talked about before, which include preventing diabetes, cardiovascular disease, cancer, improving quality of life, etc. Just to show you the reality of that, these are 8 clinical trials where people were successful in losing variable amounts of weight over a period of about a year. That's usually the length of these trials. And you can see that some of these trials were more aggressive than others. Some of them used very low energy diets, intensive behavioral therapy, some of them less aggressive, and they produced varying amounts of weight loss, varying from about 5 to about 15%. So in that kind of range that is likely to produce clinical benefits. But if we follow those individuals up for between 1 and 5 years after the end of the weight loss effort, the majority of individuals in those studies have regained most of the weight that they've lost. And the reason for that, without going into huge detail of the physiology, is that if you do successfully lose weight through dieting, there is a whole range of physiological responses that lead back to weight regain. And these include changes in gut hormones, reductions in the satiety signals such as PYY and GLP-1, increases in hunger signals like ghrelin, reductions in the fat-derived hormone leptin that is important in regulation of body weight, and a compensatory reduction in energy expenditure. All of this is a coordinated physiological response which is programmed into all of us to help preserve our body weight. And of course, for some people, those signals are stronger than others. That's partly the genetic difference in our central nervous system that means that we don't all respond in exactly the same way. There is a variation in response to all of these interventions. But ultimately, for most individuals who lose weight through these efforts, they will go back to their baseline weight over time. So that leads us a little bit to remind ourselves that this is controlled largely in the central nervous system. The peripheral signals all signal to the brain. And there is a, if you like, a homeostatic component to this, which is what I've just described in terms of the response. Of course, there are also hedonic and social factors that can influence that. But nevertheless, this is a physiologically regulated system, just the same as blood pressure or heart rate or any of the other physiological measures that we make in clinical practice. So what does help us produce sustained weight loss? Well, we do know, and these are observational data from the Swedish obesity study, which is a bariatric surgery study that was started over 30 years ago now in Sweden and has very long-term follow-up of a couple of thousand individuals who had bariatric surgery and matched controls. And you can see, using old-fashioned open operations, some of which are no longer done, that this produced significant weight loss that was sustained over 15, and in fact, we now know over 20 years. But nevertheless, that is producing stability. And that is largely, we think, because it is modifying some of these satiety signals. So should we, and this results in improvements in all of the things that I talked about before. So less diabetes, less cancer, less cardiovascular disease, lower mortality. So it's really beneficial. But the reality, of course, is that we cannot offer surgery to a third of the population. And even if we say, okay, we're only going to offer it to people with a BMI over 35 with complications or over 40, that's 1 million, more than 1 million people in this country. And the reality is we're doing about 5,000 operations a year. That's less than a tiny fraction of a percentage of the eligible population. So most people are only going to get non-surgical management. So if diet and exercise have limited efficacy, for the reasons that I've explained, surgery is great, but we can't give it to everybody. We have to fill that gap. And I think pharmacotherapy can fill that gap. And of course, this has been an area of research that has kind of been littered with false starts, littered with failures, littered with drugs that produced serious adverse events, which meant that they were introduced and then withdrawn from the market. We can think of sibutramine, rimonabant, before that, the fenfluramines, drugs like phentermine and so on. And you can see some of the red ones here, like lorcaserin, even, which is a 5-HT2C receptor agonist, introduced and then withdrawn only in the United States a few years ago. But we do now have some things that work. And interestingly, the majority of these, with perhaps the exception of orlistat, which works on the peripheral system, are working on the satiety hormones or on the brain in terms of their efficacy. I'm not going to describe all of these in detail now because I'm going to go into the ones that are available and the ones that work in a little bit more detail. So this is what we have currently approved in the UK. So for about the last 20 years or so, we've had orlistat, intestinal lipase inhibitor. It produces about 3 to 3.5 kilos extra weight loss over diet and exercise, which produces some sustainability of effect. It has to be taken 3 times a day. It has significant adverse effects, including diarrhea, reduction in fat-soluble vitamins, which means that most clinicians and patients now are reluctant to use it, although it does still have its place. It's still approved by NICE, still available for prescription. Naltrexone and bupropion is a combination drug that works on a mu opioid receptor and the dopaminergic system with bupropion, which you'll be familiar with as a smoking cessation medication. So affecting partly the homeostatic system and probably partly the hedonic system. Again, produces about 3 or 4 kilos extra weight loss over diet and exercise. Was looked at by NICE a couple of years ago and rejected on the grounds that the effectiveness versus the cost and the side effects meant that it wasn't considered cost effective in NHS. So I won't discuss that further. I'm going to talk in a bit more detail about the GLP-1 receptor agonists later on, and I'm just going to touch very briefly on the 2 that are in purple here, which are drugs that are approved for very, very specific genetic causes for obesity. The number of individuals in the UK that are currently eligible for these medications is probably, counted on only, maybe 2 hands maximum at the moment. But I will just demonstrate the power of these. So this is the first patient treated with recombinant human leptin in Cambridge a few years ago, and you can see how effective it was at producing weight loss for this genetic cause of obesity. And just in October of this year, setmelanotide has been approved for treatment of patients with MC4 receptor deficiency, POMC deficiency, and leptin receptor mutations. You have to refer the patient. There's only one physician in the UK who's entitled to prescribe this, and that's Sadaf Farooqi in Cambridge. And you have to prescribe, you have to refer those patients to Cambridge. There are genetic screening available through the NHS for children with early onset severe obesity who can have access to this highly effective medication for those rare disorders. Okay, so let's now focus a little bit on the GLP-1 receptor agonists. And we've had liraglutide now available for diabetes treatment for 10 years or more. And in the scale program where the higher dose of 3 milligrams was used, it was approved, it proved to be quite effective. You can see here weight loss of around 6 to 8%, depending on the trial. A little bit more than placebo and better than what we would expect to see with a drug like orlistat or with the naltrexone bupropion combination. And about 50 to 60% of patients are achieving a 5% weight loss, and about 30%, less than 20 to 30% are achieving a 10% weight loss medication. If we look at the effects on prediabetes, you can see that it reduces, while you're taking it, the progression to diabetes in individuals with prediabetes, and this was in the scale obesity and prediabetes study. So that's very significant over 3 years. And as a result of that, NICE has approved the use of this medication under very, very specific situations. You can read them through there, but you basically have to have a BMI over 35, you have to have prediabetes, you have to have a cardiovascular risk factor. And to make it even more complicated and politically very difficult to use it, you have to be attending an NHS Tier 3 hospital-based weight management service, which of course not everybody has access to. And if you're, as we do, some of our services are delivered in the community, that makes it very difficult, even though the care we provide is exactly the same. So there's a lot of mistakes made, I think, by NICE in doing this, but nevertheless, we've now got about 150 patients on this in Liverpool, and it does work, and I'm sure many of you have prescribed it appropriately under the NICE guidance. But as I said to you, the sort of weight loss we're seeing there, 6-8%, is good, but it doesn't necessarily get us to the point where we're going to really be able to effectively treat the complications of obesity like we see with bariatric surgery. So that allows me to introduce semaglutide, which again, GLP-1 receptor agonist, this time a weekly preparation, approved for diabetes for about 3 or 4 years at the 1 milligram dose, but tested in this very extensive trial program called the STEP program for treatment of obesity. You'll be pleased to know that I'm not going to describe all of these trials. You can see that there are more than 20 trials, of which 8 have been completed. And I'm going to touch on a few of these just to give you an idea of the effectiveness of this medication. So the main trial I'm going to talk about is the STEP 1 trial, which was the largest trial, a year in duration, or just 68 weeks in duration because of the titration period for semaglutide. Randomized patients with obesity without diabetes to semaglutide or placebo on a 2-to-1 ratio on the background of lifestyle intervention. And the dose escalation is shown here. It takes 16 weeks to reach the target dose of 2.4 milligrams. So 68-week trial gives you 52 weeks at the target. And if we look at across the completed STEP trials, you can see here that the average weight loss that we're seeing is somewhere between about nearly 15% and 17%, with the exception of the STEP 2 trial in people with diabetes, where we saw slightly less weight loss. And we've just had published a couple of weeks ago in the New England Journal the STEP Teens paper, which demonstrated similar weight loss in adolescents between 12 and 18 years of age. So highly effective compared to what we've seen before. I'm going to focus a little bit on STEP 1, STEP 3, and STEP 5. Here's the STEP 1 data, largest trial, and the 2 lines here just show the 2 different statistical analyses, one of which is effectively an intention to treat type analysis. The other word is which is they call the treatment policy estimand, and the other is the observed data. And you can see obviously with the observed data, which excludes people who drop out, you get slightly more weight loss. But if we focus on the treatment policy estimand as the most conservative, you can see we get about 14.9% weight loss. Interestingly, in STEP 3, which used a really, really intensive behavioral therapy program and a low-calorie diet, the control group did a little bit better, although you can see they were regaining weight, as you can see here in the gray line. And so they managed about 6 kilos, just under 6 kilos of weight loss at the 68-week time point. But that intensive management, although it gave faster weight loss during that early phase. At the end of the trial, there wasn't a lot of difference between that and what we saw in step 1, which I think is interesting. And if we look at the proportion of patients achieving 5, 10, 15, or 20% weight loss, you can see that over 85% of people in both of these trials achieved a 5% weight loss. Over 2/3, nearly three-quarters in step 3 achieved a 10% weight loss. Over a half achieved a 15% weight loss, and about 1/3 achieved a 20% weight loss. So we're starting to get closer to what we see with bariatric surgery. And this translated into improvements in body composition. You can see here using DEXA in a sub-study from step 1 that the proportion of lean fat mass to fat mass improved with semaglutide, whereas it didn't change much in the placebo group, who only lost 2.4% of body weight. And this translated into reductions in waist circumference as a measure of central adiposity, improvements in blood pressure, improvements in quality of life as measured by SF36, and the impact of weight on quality of life, physical function scores, although there were improvements in all of the other domains of these questionnaires as well. And we also saw improvements in lipids, CRP measured using a sensitive assay, so less lower LDL cholesterol, higher HDL cholesterol, significant reductions in VLDL cholesterol, triglycerides, CRP. About just under half the individuals in step 1 had pre-diabetes measured using the ADA criteria, so slightly lower A1C, 5.7%. If we just take those individuals, you can see that in the placebo group who got diet and exercise support, about half of them regressed to normoglycemia during the course of the trial, whereas nearly 85% of those patients treated with semaglutide regressed to normoglycemia, and less went on to develop diabetes. If we look at metabolic syndrome, about half the individuals in step 1 had metabolic syndrome at baseline. This didn't change much with the placebo lifestyle intervention treatment, whereas it was approximately halved with semaglutide treatment from 53% down to 25%. Of course, one of the questions people ask is, well, what happens if you continue treatment? Do you get sustained effect, or does it wear off over time? So that was looked at in the 2-year trial, step 5 trial, where the patients were allowed to continue semaglutide, and you can see here that at 104 weeks, the weight was pretty much the same as it was here in step 1 trial. And likewise, in step 5, we saw sustained improvements in the risk factors. Another question people ask is, well, do I need to take this drug forever? What happens if I stop it? So we did, in step 1, one of the things we did was we observed people. So after the end of the trial, everything stopped, no lifestyle intervention, just go away, do what you want to do. And we were able to bring a few hundred people from this large trial back for a repeat weight. And you can see here that there was a tendency to weight regain over time in both the placebo groups and the active intervention group. They were still at lower weight even after a year. And of course, those people that lost the most weight maintained that weight better than those people who lost less weight. But nevertheless, there is some weight regain over time, which is, of course, showing what you'd expect to see, which is, of course, once you take away the drug, things will tend to go back towards where they were before, just the same as they do if you stop an antihypertensive or a statin. In terms of safety, we don't see anything different with the 2.4 milligram dose to what we've seen in the treatment of diabetes, and relatively low incidences, things like pancreatitis and gallstones. NICE has made a recommendation, which is not yet current because the drug has not yet been launched, which is a little bit better than what we've seen with liraglutide. It can be used for up to 2 years within a specialist service. It doesn't have to be in the hospital. It can be in primary care. You have to have a complication. You have to have a BMI above 35 with appropriate adjustment for ethnicity. And you can use it really, I think that will allow a lot of people access to this treatment. We can argue about the duration of treatment, but nevertheless, I think this is a positive outcome. Okay, just a couple of other points that I want. Last point about semaglutide is that one of the big questions is, does it reduce cardiovascular events? There's a big ongoing trial, 17,500 patients, CVOT, like the diabetes trials, which it will probably report towards the end of next year. And I think that's going to be really, really important because if that shows benefit, then clearly that moves the dial even further in favor of using the medications. So finally, I want to just spend the last 2 or 3 minutes talking about some of the things that might be coming in the future, not yet available, but might be coming in the future. So one is another gut hormone, amylin, and there's a phase 2 trial done with this amylin agonist called cagrilintide that was published last year. And you can see that this is somewhere in between liraglutide and semaglutide in terms of effectiveness. So probably not going to be a great drug on its own, but nevertheless interesting. There's a phase 1 study that was published last year as well, which looks at what happens if you add cagrilintide and semaglutide together. And although this is a short study, it's only 20 weeks. So remember, it takes 16 weeks to titrate. So you're really nowhere near the maximum possible effect here. But we're seeing 17% weight loss. And we've just actually recruited our first patient into the phase 3 trial of semaglutide and amylin together, and that is ongoing. The other one that I think has caught a lot of people's attention is tirzepatide, which is a GLP-1 GIP receptor dual agonist produced by Lilly. And that is approved in UK and in Europe and the UK and the United States for the treatment of diabetes. But there are ongoing trials for obesity. And the first of these trials, using exactly the same doses that are approved for diabetes, was reported a few months ago. And here we're seeing, depending on which estimand we use for outcomes, somewhere between 20 and 22% weight loss at the highest dose. So it looks like it's potentially even more effective than what we've seen with semaglutide. And I think that is really quite exciting, especially as we also see at the highest dose improvements across the board in all of the expected risk factors, as you can see here, with pretty good results even at the 2 lower doses that we've tested. So I think we are starting to bridge that gap. We're starting to maybe threaten the surgeons. I know that there are some surgeons here. We're going to put them out of business soon. And there's a few other things that I think might take this, even further. The idea of combining gut hormones, trying to mimic the effects of bariatric surgery hasn't, the pharmaceutical companies and academics have been working on this for a long time. I know Trisha's done some work with PYY and GLP-1 and so on. And just a couple of interesting things here. So this was published very recently. This is a triple glucagon GIP and GLP-1 agonist. And the phase 1 study here, well, the phase 1 studies show it reduced food intake in a single dose study, but in mice, it seems to be more effective than tirzepatide. I can't tell you any more than that, but I think it looks really quite interesting. And in fact, just yesterday, Amgen produced a press release around AMG 133, which is interesting because this medication actually is a GLP-1 receptor agonist combined with a GIP antibody. Now that may seem a bit counterintuitive given from what we've seen from tirzepatide, but the story that Amgen are putting out, and where they've done some really nice data that supports this, is that actually chronic GIP agonism actually downregulates the receptor, and actually what you really want to do is antagonize GIP. And their phase 1 results, which we haven't seen in detail, but they've put in a press release, suggests, and this is a monthly injection, shows that up to 14.5% weight loss after 12 weeks. And they are also going to be starting a phase 2 study in 2023, which I am involved in, so I'll declare an interest there. So to summarize, weight loss is difficult because of multiple physiological mechanisms that serve to progress against negative energy balance. Although we have modest success with diet and lifestyle, surgery is clearly much better, but we can't give that to everybody. I think we do now have good evidence for pharmacotherapy at reducing some of the complications. And we've got a whole range of things that are coming along that are much, much more effective than anything that we've seen before. Clearly, we need to see the results of the long-term cardiovascular outcome studies. But if those are positive, then I think we are, really are entering a new era for pharmacotherapy. And the surgeons probably need to start worrying about whether they're going to have anybody they need to operate on. Thank you.
Thanks, John. Right, we'll open to questions. Any questions in the audience?
So we have questions here and online. So
I'll start with an online one. So is there a particular kind of patient who respond best to GLP-1?
Yeah, that's a really good question. It's one that obviously the pharmaceutical companies have been really interested in. So they've done, in a lot of these studies, they've collected genetic data, they've looked at predictors of response. What we know so far is that the only predictor of response is early weight loss. So if you do well at the beginning, you're likely to do better later on. But that is the only predictor of response. There's nothing else that really comes out. Women tend to do a little bit better than men, but that may just be a function of body size.
Thanks very much. That was really interesting. Just a very quick question. Is there anything about rate of change in weight loss in terms of sustaining weight loss for the future? Thinking about these trials that seem to focus very much on quick weight loss.
So there have been trials that have compared those things using lifestyle interventions, and obviously I haven't had time to describe those today. But what they suggest is that the long-term effects are, it doesn't matter if you go fast or you go slow, the end result is likely to be very, very similar. And in fact, as you know, there's a lot of interest in the sort of very low energy diet or low energy diet approach using liquid meal replacements for diabetes prevention and for pushing people from diabetes into remission, like the DIRECT trial. And because those people the people who are able to follow those diets do really well at the beginning. Obviously, if you get down to a lower body weight, as I showed you in the STEP trial, it takes you longer to get back to your baseline. So in some ways, actually going fast could be beneficial, but not too fast. I think there's a kind of steady balance. But a lot of people don't like these we offer them in Liverpool, but a lot of people don't want to take liquid meal replacements. Cost, inconvenience, loss of the social aspects of eating, all those things make it very difficult.
John, quick one. Exercise. So, I mean, these are great. They work. Clearly, Zapatide looking amazing. But there's pretty good data on exercise and you don't lose weight. It's still beneficial. You're just not going to get that. So this needs to be obviously
so physical activity has lots of benefits. As you probably know, I'm a little bit of a fanatic, but that's kind of my own personal problem. So I do think exercise has lots and lots of benefits for health. But in terms of on its own as a weight loss intervention, if you look at those few trials that have been done where people have tried to clamp the intake and done supervised exercise, really proper supervised exercise, which a lot of people with severe obesity just can't do, might give you an extra 2 or 3 kilos over 6 months if you really do it well. And that would be 5 times a week, on a treadmill, pushing yourself really hard. Most people don't have the time or the ability to do that. So I think exercise is great, but as a weight loss intervention on its own, it's not very helpful. Yeah. Lots and lots of benefits of exercise. I don't dispute that. But the difficulty is, I mean, just to give you an example, the patients that we see in our weight management service have an average BMI of 48. When we started our physiotherapy intervention, we tried to model it on a cardiac rehab program. The cardiac rehab program was far too aggressive for these individuals. Their ability to exercise was very, very limited. You have to start, you're working often from a very low baseline. It makes it hard.
Okay, John, one last question. I think with the NICE guidelines coming out, in terms of the use of GLP-1 analog and semaglutide for just 2 years, I think we've got questions from the audience, is that you've shown, when they, in the step 1 patients that were taken off treatment, they regained weight. So our question, what should we do after that 2 years? Do you think there's going to be more bariatric surgery, or should we continue these ones lifelong?
That's a really important question. And I think it's something that was discussed at length during that NICE committee. And it's really difficult. I think one is, if we get the results of the SELECT trial, which on the average duration of treatment is likely to be around 4 years, I think that might allow us to change that argument before the people who are starting on semaglutide in the next, because it's not going to be available probably till the summer next year. So, by the time those first cohort of patients have reached 2 years, we may actually have a change in the guidance because we may have more evidence. The other thing is whether and I think there's a study to be done here, is actually looking at intermittent treatment, where you see how, because different people will, as I showed you, will regain weight with different trajectories. So some people will actually be able to maintain that weight long term, and they won't need a second course of treatment, but others will regain, and depending on when they reach a threshold, you could then give them another course of treatment, and that may be an appropriate way of thinking about it.
There's so many questions still, I think, but we have to move on to the next speaker, but hopefully we can continue to ask questions at the coffee time. Thank you very much, John. Okay, we're going to next welcome our next speaker, who is Dr. Dev Bansi, who's our consultant gastroenterologist here at Hammersmith Hospital. Dev's had over 30 years experience and is going to talk to us about non-surgical bariatric procedures, of which I think is in the last few years, there've been lots of exciting development, and offers alternative to patients who either don't do well with medical treatment, complement medical treatment, or don't want bariatric surgery. So over to Dev.
Thank you. Slideshow. Great, thank you. Good morning. Good morning, everybody. Well, thank you for the invitation. I think in fact, Sanjay, who's following me, and I are probably the only people that play with toys in the department, in the sense of using technologies that are emerging. And one of the things that I've been doing over the last 7 years at Imperial is concentrating on bariatric endoscopy, and it's also referred to as metabolic endoscopy. So when I was asked to give this talk, it was to really try and highlight some of the developments in the field, but also to give you some sort of context, because John has highlighted the fact that there are lots of drugs available, and one of the charts that that you put on at the end, you talked about the different spectrum of treatment options that are available. But you forgot to mention endoscopy, John, because endoscopy is a big part of the armamentarium. I'm actually struggling to change my slides. Oh, here we are. Okay, so essentially, endoscopy plays a role in different sections of the journey for a patient who's overweight, ranging from the preoperative stage to the perioperative, and also to the post-operative stage when, God forbid, if there are complications, and we get asked to deal with them sometimes. But also, what's important is to understand that the endoscopy does have a role, I believe, and this is an expanding role in delivering therapies, primary therapy. Now, this is a slide that's quite old, as you can see, and it's quite commonly used, but the purpose of putting it up today is to highlight the fact that in 2000, when this comment was made, who felt that surgery was the only viable option, because at the time, drugs and pharmaceuticals and exercise all failed treatment. So when I started as a consultant here in 1999, this is what the management of obesity was all about. And we know that surgery is an option, but we've heard that only 1% receive it. Fewer patients receive medication they ought to. So there's about 99% of patients that have an unmet need in terms of management of obesity. And even though there are newer drugs available, as you've heard, there is still the fact that some of the drugs don't work for significant proportions of patients. So therefore, there has to be another alternative. Now, surgery has been that alternative for many, many years, but we've also heard that surgery is not available to the vast majority of patients for a variety of different reasons. So therefore, in the last few years, what you've seen is an emergence of endoscopic, bariatric, and metabolic therapies. And this truly is the birth of a new field in endoscopy. And the UK, unfortunately, is quite far behind on all of this. Now, the benefits of endoscopy in terms of delivering this sort of therapy are quite important to understand. It's organ sparing, it's safe, it's effective, it's minimally disruptive, and we like to think that there are no long-term consequences. So we would propose that there is a new shift in therapeutic options, and the gaps that have been left behind by current therapies can potentially be filled by newer therapies, not only newer drugs, but newer endoscopic therapies. And what's important, and John's already told us, that we've got to start appreciating that obesity is a disease. It's not a lifestyle choice, it is a disease. And if you accept that, then there are a variety of different things that come with that. And it's also important to remember that obesity is not, you don't offer a one-off therapy to these patients. You've already seen that if you stop the drugs after 2 years, patients put on weight again. So there's a continuum of care, and that continuum of care is not delivered by one specialty. It has to be delivered by multiple specialties, and it's often going to be combination therapies. And this is why endoscopy has a real role to play. Now, there are a whole range of different techniques and technologies that are either currently available or emerging onto the market, and they vary in efficacy, they vary in feasibility, tolerability, safety. And what I mentioned already is that in the UK, we are slightly behind. The Americans and the Europeans are much further ahead. They have statements, they have position statements from their endoscopic societies, and they see endoscopic therapy potentially as a bridge to surgery, or they may see it as part of a structured weight loss program. They see its positioning as a primary therapy as well. And we have to remember that not everybody needs to lose 40% of their total body weight. Different people need to lose different amounts of weight. Therefore, different therapies are relevant for different individuals. And we have to ask, what do our patients want? We have to select those patients for endoscopic therapy that are appropriate. There are lots of questions. We have to find out who should be doing these therapies, because not every endoscopist will be delivering this. And of course, we have to try and work out how much it costs. And so what I wanted to do is just concentrate on 2 or 3 of the main therapies that are currently available and utilized quite often, both in the UK and abroad. And you'll be familiar with 1 or 2 of these. Clearly, intragastric balloons have been around for a long time, and there are a variety of different balloons. All of them, bar the one on the right, the ellipse balloon, are delivered endoscopically. They're all removed endoscopically. Putting a balloon into a patient is not technically very difficult. It takes about 20 minutes. It's done usually under sedation. The difference with the ellipse balloon on the right is that it's the first of its kind swallowable balloon. So literally the patient swallows this capsule, which you see there, and that is where the balloon is, if you like, deflated. They swallow the capsule wide awake, and then we take an X-ray to demonstrate that the capsule is actually sitting in the stomach, and then we inflate that balloon with a giving set, much as you see with a drip attached to a patient on the ward. And once you've filled it, you take another picture to make sure that the balloon is in the right place, and then you pull the cord, and the balloon then basically detaches from the cord floats into the stomach. So it's actually very technically easy to do. Again, it takes about 15 or 20 minutes. And what you see with a variety of different balloons is that weight loss can be achieved, which is variable level, but sits somewhere around that sort of 10%, if you like, where you are hopefully going to have an impact on some of the comorbidities that it is that you are looking to prevent. So it is a therapy that is available. It's been around for a while, and it is effective in the right patient. But what I want to focus the talk on really is the technique of gastric plication, because this, I think, is going to be a game changer in the delivery of weight loss techniques endoscopically. Now, gastric plication, as the name refers to, is simply going into the stomach endoscopically and suturing the stomach so that you achieve a volume reduction in the region of about 70%. And there are different techniques that are available, and I'm not going to go through them all, but I'm only going to talk principally about the one at the top, which is overstitch. Overstitch is a technique whereby you suture the stomach. These are all techniques of endoscopic plication, by the way. They're all delivered through the mouth. There's no surgery involved, but overstitch is the one that you may have heard about. In fact, it was in the news just 2 days ago. The company Apollo Endosurgery that's been pioneering that work has just been bought out by Boston Scientific for 615 million pounds. So Boston Scientific see that this technology is the technology of the future for endoscopic therapy to deliver weight loss. And essentially what you are doing is you are mimicking, if you like, a surgical sleeve. I know Sanjay is talking straight after me about surgical techniques. And one of the things that it's a bit of a shame is that people talk about a surgical sleeve and an endoscopic sleeve in the same context. They are actually not the same at all. There are differences both in terms of how you achieve the end result, but also in terms of some of the hormonal changes and various other aspects. So we are talking about slightly different techniques, which is why the weight loss achieved with a surgical sleeve is often quoted in the region of about 30%. And as you'll see, weight loss achieved through this technique is less than 30%, but not far off. This is a video. I just wanted to see if we could play this. So this is a video of an endoscopic sleeve that I've done, where you can see it's done in theatre, and it's a bit of a fiddly technique. So you have the endoscope, which is loaded with this device, which is the Apollo overstitch device. And then what you can see from the dexterity of the hands is that there is a bit of fiddling that goes on, and you are literally suturing. So you are taking a curvy linear needle and you are placing it full thickness through the stomach wall. And we know from laparoscopic models that this is full thickness suturing. And it's really critical to get that full thickness bite. If you don't get that full thickness bite, then what happens is that the sutures will fall off, and in time, the patient's stomach will expand back again. So that is really important. And we use these little bits of what we call helix devices to pull the tissue into the scope, and then you plicate from the distal end of the stomach all the way up to the fundus. You can apply longitudinal plications to shorten the stomach, and then horizontal ones to contract it in the horizontal plane. So you actually end up with a reduction longitudinally and horizontally, and you achieve a very nice looking sleeve. So this is the end result, where we're in the antrum there, and then as the camera comes back, you can see that the left side, which is the greater curvature of the stomach, has been sutured, and you've achieved a volume reduction of about 70%. Now, a few years ago, if I stood up and gave this talk, one of the criticisms would have been, well, where's the evidence that this works? And that evidence, I'm pleased to say, is now here. There have been large studies done in different parts of the world. There have probably been around 50,000 patients treated with this technology. The 5-year data for follow-up is there. There is evidence that you achieve in the region of 17–18% weight loss at 5 years. The utility of this technique, the applicability of it, and the safety profiling was further highlighted by the study, which was published from a multi-center study published from the US recently, the MERIT trial, where they took 200 odd patients and randomized them to either the technique or to lifestyle changes and achieved significant amounts of weight loss with a very good safety profile, which then led on to the FDA approving this technique for weight loss as a realistic option. And that's kind of been the springboard, if you like, that has meant that Boston Scientific have come along and bought out Apollo Endosurgery because they see this as a real potential. Skip that. This is just to demonstrate the fact that 5-year data is out there now demonstrating its utility in terms of weight loss. 5 years, mean total body weight loss 15.9%. And again, demonstrated on a graph, just the same data there. Now, I mentioned that the Apollo device was the device that we tend to use. It's the go-to device, but there are other devices on the market, and effectively they are achieving the same thing. They're plicating the stomach. So this is one of the platforms that is used. And again, rather than suturing here, what you're doing is you're literally taking a staple gun endoscopically and plicating big chunks of folds of the stomach to reduce the volume. Things are moving on. There are now automated technologies becoming available so that you literally have a robot which you introduce into the stomach, which then does the suturing for you. Now, these are not human trials that are being done. These are animal trials, but I dare say that it won't be long before this technology is also available in the clinical arena. So what do these techniques achieve? Well, this is just to demonstrate where ESG sits in terms of the amount of weight loss. So you see the drugs intensity of exercise on the left, and then as you travel across the horizontal axis and get up to the surgical side, what you see is the ESG at 1 year can achieve more than 10% weight loss in at least 3/4 of patients that are treated. So I think it's really there now as an option. We tend to have a lower BMI range of patients. We sometimes do operate on super obese because it might be a bridge to surgery. There may be some patients, as Sanjay may mention later on, that are not suitable for surgery where this technique may be relevant. So there are very specific indications. There are very few side effects, less than 1% really in the major series, and they're not major side effects either. They're often pain or a bit of bleeding or small perigastric collection that can be resolved without the need for surgery. So plication definitely has a future for weight loss management. And the issue really is that, again, it's not a freestanding technique. What you will find is that there will be combination therapies. So there is data that looks at the combination of, for example, ESG with liraglutide. And yes, you do achieve additive weight loss. So no doubt there will be options to treat patients with combination therapies coming along. Now, just to finish up, because endoscopic, so balloons is one technology that we have, endoscopic sleeve plication is another. There are a few other devices and toys on the market that are not mainstream. Aspire, Assist, this is essentially what was being done in the States until it got stopped, but it was FDA approved. So you essentially had a patient who had a peg tube inserted, the equivalent of a peg tube, and after 4 or 5 hours after eating, they would aspirate out of the peg tube so that they wouldn't absorb those calories. Now, you may think that's a really perverse way of losing weight, and I agree with you, but the FDA approved that. There's a whole range of other techniques which concentrate not on the stomach, as the first two I mentioned have, but on the small bowel, because we all know now that the physiology of the small bowel is really very critical to achieve weight loss as well. So there are a number of techniques whereby you can inhibit the small bowel, if you like. Endobarrier was one of those. In fact, Imperial was involved with the endobarrier trial. It was a very successful trial, But the problem was that the data from the US that came out a few years ago wasn't so advantageous. There were some side effects. There were a couple of deaths related to hepatic abscesses. So in fact, the technique was withdrawn, but the effects achieved in terms of weight loss were good. And again, it illustrates the fact that the small bowel does play an important part in weight loss maintenance. This is not science fiction. This is becoming science fact. The use of magnets, which can be delivered. So you deliver a magnet through the top using an endoscope. You go down into the small intestine. You then apply a different endoscope or a colonoscope from the bottom end. You go into the terminal ileum, and then radiologically you can superimpose, deliver a magnet from the top, a magnet from the bottom. The two magnets stick, and they achieve a bypass. So you can achieve an endoscopic bypass using magnetic technology. My colleagues at King's are doing these sorts of jejunal-ileal diversions, and there's a trial ongoing there at the moment. We were involved, or I was involved here about 5 years ago with Alex Moraz, who's gone to Ireland, but he was conducting a trial with one of the research fellows on the use of DMR, duodenal mucosal resurfacing. And in fact, we were doing that trial looking at insulin resistance in PCOS patients to see if that could be improved. But DMR technology, which essentially it involves either heating or cooling the duodenum from the papilla onwards to perhaps the ligament of Treitz. There is evidence that technique can improve diabetes, type 2 diabetes. There are trial data for that. Unfortunately, the trial for insulin resistance improvement in PCOS patients wasn't conclusive, but I think that may have been number related. The point is that there are technologies available endoscopically delivered to affect the small bowel as well. And the bile duct and biliary diversion. So I'll skip through these. This is an interesting one because so far what I've done is I've talked about techniques that are either stomach predominant or small intestine predominant, but there is also around the corner technologies that combine the two. So here, for example, you create an anastomosis, a bit like a Billroth bypass, if you like. So you've got this thing here, which is an anastomosis between the stomach and the small bowel, so food can go straight through into the small intestine, but you've got to then block off the pylorus and the duodenum. So you have a balloon that blocks off the pylorus and the duodenum, and you achieve a bypass in two steps. So these technologies, as I say, they are in trial development. They're not available mainstream. And similarly here, inflating a balloon with an endobarrier equivalent attached to it, so you achieve a combination effect in terms of weight loss. So just to finish up, some of these are practical, some of them are theoretical, but the point is that they're all very exciting and they are not the future. Some of them are science fact. So we need to really ask other questions. Who should be delivering these technologies? How should we be delivering them? And who's going to pay for them? And these are the sorts of questions that remain unanswered, I'm afraid. So to summarize, there is convincing evidence of the use of endoscopic bariatric metabolic technologies. Where they sit is very clear in terms of the treatment options. What we really need now is an acceptance and an understanding from NICE and our colleagues that these technologies do offer something that is a benefit to the patients and just gives us another option to achieve weight loss in these people. So thanks very much.
So there's a question online concerning the use of botulinum toxin in weight loss.
Yeah. So Botox, you can inject Botox into the pylorus or into the antrum. And the rationale of that is that you achieve delayed gastric emptying. So the problem with that technique is that it's useful in patients who have gastroparesis. So you paralyze the pylorus by injecting it into the pylorus. So it's not a very effective technology for gastroparesis. But in theory, if you inject it into the antral area and you achieve some stasis in the stomach, you improve, you create a feeling of fullness and satiety. So you achieve weight loss through that method. But actually, it's not that effective.
Okay. Dev, how much do these procedures cost?
Well, the cost of the tech, for example, the cost of the device, the Apollo device that we use, a single-use device, it's probably in the order of about £1,000 just for the kit. But then, of course, you have the theatre time, you have the nursing time, you have the medical time. So on average, it would be probably in the region of about £2,000 to £3,000. Now, there was a technique which I didn't put up, which is what do you do in those patients that have put on weight post-surgery? What can we offer them? Because we can offer similar technologies. And the PCTs paid us at Imperial, as you probably know, to fix these patients. And each of those patients, the tariff attached to that was about £5,000, which was the equivalent, I think, Sandy, of a tariff attached to a bypass procedure. So the point is that yes, they're not cheap, but they are effective, and we're not indicating or implying that they should be used in every single patient, but there is a definite group of patients where there is a role.
Some patients are put off the idea of surgery because it's too irreversible, and would like an endoscopic procedure thinking it might be reversible if there are complications or side effects, or they're not happy with it or whatever. But nothing you've described sounds particularly reversible endoscopically.
Well, no, actually, these are just sutures. They're not, you know, if you did a gastric sleeve, you'd take a staple and you would create a tubular structure and you'd throw away that part of the stomach. Here, what you're doing is literally putting non-absorbable sutures into the stomach. Now, you can go back and cut those sutures. Those patients can actually also go on and have formal bariatric surgery if they need to, if they haven't achieved satisfactory weight loss through that technique. So in that sense, they're reversible. They are organ sparing. But if I suppose the next question is, so if you cut the sutures, is the stomach going to spring back into its normal shape? The answer is no, it won't. But you haven't actually removed any of the stomach. So therefore, you're not subjecting these patients to lifelong vitamin supplements and various other things.
Morning. As a surgeon who's strayed away from the gut for a while, I've been absolutely fascinated by your talk and heard an awful lot of things that I hadn't heard of or haven't heard about for a while. Back in the 60s, people were swallowing magnets and then having magnets rolled over their abdomen to try and prevent adhesions, and it didn't work. I just get the sense that industry's running away with all of this. Could you just reassure me that there's a bit of governance and that gastroenterologists and surgeons and endocrinologists are actually meeting and talking to each other to come up with some sense? Because it seems clear to you where your natural orifice surgery lies in the algorithm, but it's not clear to me.
Yeah, no, I think you make a very important point. I think that what we have to be very careful about is that we select the technologies that work. And in fact, the American Surgical Society drew up guidelines on management of surgical management, this is of obesity, which were only published, I think, yesterday. The previous guidelines, I think, dated from 1991. Now, in endoscopy, we don't have the BSG, the British Society of Gastroenterology, does not have any current guidelines on where bariatric endoscopy sits and who should be doing it and who we should be training to do it. And of course, the reality is that we can't get away from the fact that industry is going to play a big part in that. And industry is at the table, has a seat at that table have those discussions. In fact, I'm one of the co-authors on the BSG's guidelines for bariatric endoscopy. But you're absolutely right. The governance part of this is really critical to its success and also to wider acceptance, because ultimately, as we've heard, some patients do not want surgery. And there is a role for this, but we have to be very careful because we're on this sort of cusp of a wave. The technologies are now available that they were not 5 or 6 years ago. We just got to make sure we use them properly. I agree.
Okay, thanks very much, Steph. We might get you to help us answer more questions. So to round off our obesity session, I'd like to introduce Mr. Sanjay Pukayasta, who's our consultant bariatric surgeon, who basically has published extensively in obesity research, bariatric surgery, and currently actively involved in many studies. So over to you, Sanjay.
Thank you, Tricia. Thank you, Fausto, for inviting me. Thank you, Kareem, for taking me through finals 24 years ago. He doesn't change. I don't know what it is. Is that why you became an endocrinologist, Kareem? Because clearly there's some longevity thing that you're doing that is amazing. He taught me in 1998, which seems a very long time ago. But anyway, thank you very much for having me. Before I start the talk, I just want to reassure a surgical colleague that there is massive governance in bariatric surgery. There are international governance bodies that mean that this has to be a multidisciplinary team approach with the focus of the patient being the primary important focus for all the therapies. Dav actually is one of the most helpful colleagues in our MDT. And the reason I'm also saying this is I'm very sad because Dav is leaving us in January for pastures greener, and he really is an innovator. But he is very much involved in the governance. So I just want to reassure you. So I'm a bariatric surgeon. I'm an upper GI surgeon, and I think it's useful to understand a little bit about me because I'm a bit different. So I actually trained as a colorectal surgeon, and I trained with people that I found didn't really want to kind of look into the metabolic issues that cancer patients have. And I stumbled into bariatric surgery because my then boss forced me to do a debate against a chap called Rubino, who is a really famous professor of bariatric surgery in the States. And at the time, I was barely a registrar. But Francesco invited me to Cornell and said, why are you doing all of this pelvic poo surgery? Why don't you learn this stuff? Because your skills are transferable. And 15 years later, here I am talking about bariatric surgery. I have looked into robotic surgery. It's made no difference to my practice. We were the first team to use robotic surgery in bariatrics in the UK. I do a lot of benign upper GI surgery. We've used other devices. I'm very into the digital aspect of surgery and standardization. We use AI and ML in my operating theater. We were the first team to do it and do it regularly. I work with Fausto in the other sector. I'm putting this slide up for two reasons. Firstly, John is from Liverpool and Dev loves Liverpool Football Club. So I had to put something up about Chelsea just so that he gets to see some blue. But the real reason for this slide is that the second picture is that of my team. And we had a dinner recently, and these are the fellows and trainees who I have trained and are training for the last 13 years as a consultant and senior lecturer. That's my wife who came to join us all. And the reason I'm putting that up is that is really what bariatric surgery is about, because we cannot manage these patients without endocrinology, pharmacotherapy, physiotherapy. And it's really about working together and collaborating. And it's not just in the clinical forum, it is with industry, it is with academia, and it is mainly with people who are interested to change this disease that is obesity. And bariatric surgery has its name from a term which is not very nice. It's about baros. It is the pressure within the air, it is pressure and overweightness that was coined to make this term bariatric surgery. And actually, it should really be called metabolic surgery. And some of the procedures that don't have metabolic effects for example, the gastric band, I am not a big proponent of. We shouldn't be offering these surgeries and these procedures in the NHS because they are not cost effective. There are various classes of obesity. And again, the way that we class obesity, in my opinion, is not the best way. Because if you look at the current England rugby team, I know that they're not doing very well, but it's not because they are fat, but their BMI would class them as obese, but their muscle mass is huge. So we do need to change lots of things that we look at for definition, and the definition of weight loss and how we manage it is also really important. So at the moment, what can we do? Tier 1, need to lose some weight, go on a diet yourself, go to Slimmer's World, go to the supermarket and look at the diet section of the aisles. Number 2, tier 2, a little bit of guidance. You go to your GP and you say, I need to lose some weight, doc. And they say, excellent, go and try tier 1. That's what tier 2 is, okay? Then there's tier 3, which is come into the hospital and be supervised. And actually that does have place and it does help some patients, but the research that John and Dev have already alluded to shows that long-term change in weight loss, unfortunately, isn't about energy in and energy out. Then there's tier 4, which endoscopic therapy is a part of, which is surgery, which I'm going to spend a bit of time talking about. Then there's tier 5, where there is a lot of future in bariatric surgery because it is about fixing problems and it is about sorting out issues, particularly with what COVID has done with bariatric tourism. We're admitting 2 to 3 patients a week who have gone to Turkey, Czech Republic, and various other places and had all kinds of weird surgery that doesn't work and is done badly. But most importantly is the last line in this slide, because it is about combination therapy. Because if you work, and I will give you anecdotes from my private practice, if you work with patients truly in a longitudinal way, and you offer them lifestyle behavioral change with a bit of pharmacotherapy to get them to somewhere, and they don't need you again, that's amazing. But if they come back and they need you, it's not just about rearranging their giblets and doing a bit of keyhole plumbing. It's about then continuing to support them with psychotherapy, pharmacotherapy, change in lifestyle, because we have to change those chemicals in the brain that make us decide that's a poor food choice. I'm going to do that. I'm going to eat more. I'm really full, but I'm walking past this place that's frying donuts and I'm going to eat it. Those are chemical messengers in our brain. And these chemical messengers, we didn't know they even existed 20 years ago, but bariatric surgery has allowed us to understand these pathways. So that's another role I'll talk about briefly. There are guidance and structures for what we should be offering in the UK. You should all know these, and I won't go on about it. The only one line is, it is the only nice guidance I've seen where there is an ethnic difference in what you can have. And I think that is really, it's a way of understanding and stratifying risk from a genetic basis as well. Lots of obesity-related comorbidities and all of these things, so gynecologists, ENT and sleep physicians, cardiovascular clinicians, the endocrinologists, everyone refers to us. And that's why we are busy, because things need to get sorted out. It was alluded to that we only do 5,000 cases a year in the UK. That's almost accurate. COVID kept that the way, but it is changing again. But in America, it is exponentially growing. And in the UK, the numbers of 5,000 are in the NHS. And actually, there's triplicate numbers in the private sector. And all of that data now, as you'll see in a second, is also available and transparent online. Because one of the other things that bariatric surgery has achieved is transparency in data, national bariatric registries having to be used. It is the only subspecialty other than cardiothoracic surgery where if you don't put your data online, the Royal College will name and shame you every year. And then you will not get indemnified and you will not have patients. So in the 3 years, including pandemic, there were about 21,000 cases in the UK. We did a lot of them in the NHS at our centre. There are 4 deaths across the whole of the country in those 21,000 cases. So the mortality is better than having a lap chole in DGH. The average BMI is over 50. The average weight was over 141. The majority of my patients are female because they have better health-seeking behaviors, not because men's obesity is any less. Essentially, women are more sensible than us. The number of obesity-related diseases was just under 4, and the majority of patients stayed for less than 3 days. We have our data online, so you can type my name into the National Bariatric Registry, and you can see how many cases do I do. Obviously, I put this up because I'm a competitive surgeon. I like to be in gold, and I like to be on that end of the graph. But volume in surgery is really, really important. And if you don't have volume, you get rusty. And the sort of things that we are pushing the boundaries of, you cannot have a surgeon being rusty. Procedures, I don't need to go through the endoscopic things really, because Dev's done that, but the adjustable gastric band should really not be offered in the NHS, in my opinion. The sleeve gastrectomy is actually the only irreversible bariatric procedure. So I'm going to say that again, the sleeve gastrectomy is the only irreversible bariatric procedure. None of the others are irreversible. They're all very straightforward if you know what you're doing to reverse them. And so that is something that we need to communicate to our patients. We also need to communicate it to our colleagues because they need to learn how to reverse the operations. There are newer procedures that are out there that we are trained to do, but NICE is still sitting on the fence about them. And they will probably have really good efficacies because we've got excellent data from abroad. But yet again, the discussion between NICE and clinicians and patients is taking a bit of time. Dev, you can see I didn't ignore your subspecialty, but I did put it in blue, so forgive me. We mainly do bypasses and sleeves, okay? And in my humble opinion, if we're going to offer one operation to the majority of the patients in the NHS, which is rationed, broken, and broke, it should be the Roux-en-Y gastric bypass. It does achieve the best weight loss. It does have the best change in neurohormonal gut profile of the biochemistry. It is reversible, and it has been far and away the most studied for the last 76 years. And so if we're going to offer one procedure, that is the one, in my opinion, that it should be. We're doing more and more revisional surgery. I do about 20% revisional surgery, and that's the main reason for that is I spend my whole life taking other people's bands out and taking people who've gone abroad for a non-regulated surgery to get fixed. But the primary procedures for the right patient, and I'll come to that in a second, work. Majority of my patients stay 1 or 2 days. We have an enhanced recovery pathway. They're up and about within 3 hours. They're doing breathing exercises. The majority of them are doing, proper modulated exercise routines within a week to 10 days. When do we not operate? We don't operate if they don't qualify for surgery. I'm going to say that again. We do not operate if they do not qualify for surgery. You have to be quite rigorous sometimes. The MDT this Thursday was exactly that. There was a patient who just wasn't the right BMI and very high risk. We can't offer surgery to them in the NHS. There are other patients who have hostile abdomens. They have had abdominal disasters in other places, and they are very, very challenging, and you can't actually do these operations on them because everything is too stuck together. That is where endoscopic therapies will be really helpful. Patients that don't want to have little cuts on their abdomen. I've had laparoscopy, had a burst appendix about 15 years ago. One of my current colleagues took out my appendix. It is very minimally invasive, but some people don't want it, and we have to respect that. And for those people, pharmacotherapy, endoscopic therapy, and other therapies are obviously available. Why am I even giving you this talk? Because John has shown you the graphs in his first talk from that NEJM paper, and it just shows you that the ability to have 30, 40, even more total weight loss, I think that's the graph that you showed, John, it's there and it's available. But the patients need to understand that their lowest weight won't be their final weight, and that we're not magicians, we're just really good plumbers. And if they don't follow the guidelines, they don't have the lifestyle change, and they don't use this catalyst, the tool that we put in their body to understand to live in a different way, they'll put some weight back on. And that's what it is. Bariatric surgery allows us that catalyst for 2 to 5 years for patients to understand how to live in a different way because of that metabolic change. It reduces death, it reduces the risk of all of these cardiovascular comorbidities. Does it work? Joanna would say so. She's one of my previous patients. She's happy to have her pictures up here. When I met her, she was in a very bad place in her life. She's actually an NHS patient. Subsequent to her surgery, she lost lots of weight. She wasn't diabetic. She didn't have sleep apnea. She has met a partner, and now she has 2 children. And we got her, because she's so vivacious and so positive about life, got her to meet Prince Charles when he opened our unit. And he asked her, why are you standing next to the surgeon that operates on fat people? And she said, because I was a fat person. And so, you know, she is very open about it, and she's not the only one. There are many patients like that. Good MDT, good MDT, good MDT, good colleagues, good colleagues, good colleagues. That is the secret to success, not in bariatric surgery, but in any surgical specialty now. Take trauma. We have bedside trauma MDTs. Okay, take orthopedics. They have orthopedic MDTs. Go figure. When I was doing orthopedics in 2000, there was no such thing as an MDT in orthopedics, and it's even there now. So we have to optimize the patients. We have to engage with the patients. We have to reinforce the information. A lot of that requires digital technologies. We have to manage not just the patient expectation, but the clinician's expectations, i.e. the GP, but also the family's expectations, because without that, people get upset when they only lose 15% and not the 30% of the weight loss that someone's promised them. We have to be careful about case selection. There are lots of challenging patients we are now being referred because we've become good at what we do. You know, the Brompton refers us patients that are waiting heart transplant. That really upsets my anaesthetists, but you know, we find a way with the MDT if we feel it worth their while. And I truly believe I shouldn't really be here giving this talk. I shouldn't have ever needed to go from colorectal surgery to bariatric surgery. I should be a thing of the past. Bariatric surgeons should be made extinct. And when I say this, it really upsets my other bariatric colleagues, but that is the truth. Because if government get together across the world and society gets together across the world, we should be able to change this societal disease without me doing an operation. But I do enjoy it. We have 4 anaesthetists at least, 3 specialist nurses, dietitians. We now have 6 physicians, and they're all excellent colleagues. 4 psychologists, a psychiatrist, the booking coordinator, dedicated fellows, surgical registrars, juniors, 5 surgeons. We've just appointed a new consultant colleague who's of Spanish origin and probably the best fellow we've ever had. And we were doing 500 cases pre-pandemic and continued to work during the pandemic because we found a way to look after our patients. This is just some clips of the registry. It's online. You can look at all of our data. And the reason I put these slides up there is to show you that transparency and openness and learning from your mistakes is essential in a specialty like bariatric surgery. It is very high risk. And if you start fiddling around with people and don't share your data and have lots of complications, you should stop, think about what you're doing, relearn, come back again and be supported. The pathway can be complicated because the patients are complicated, but we have a pathway of managing all of these things. There have been procedures in the past, like the VBG, awful procedure, awful. Awful for 2 reasons. 1, doesn't work. Awful for second reason, very difficult to undo it and revise it to anything else. The whole of the Middle East is spattered with VBGs. There are about 4 million VBGs waiting to be reversed all over the world, and they all come mainly to us because no one else can sort them out laparoscopically. The band, as I said, it shouldn't be offered in the NHS. Doesn't work, doesn't help, is too unmanageable, and patient expectations are poor. We should take it out of the NHS. The sleeve, a newer operation, by newer I mean 19 years old, has good weight loss, 30 to 40% total body weight loss, but has problems potentially with long-term reflux, more risk of Barrett's, risk of esophagitis. And yes, it is permanent, which actually some patients like. Some patients come to clinic and say, I don't want an operation that's reversible. I want you to change me forever. The jejunal-ideal bypass, the BPD and the BPD with switch are things of the past in most of Europe. And the Roux-en-Y, in my opinion, and I'll show you a video of that in a second, is really the gold standard. I'm not going to go through the endoscopic therapies. There is a slightly newer operation. It's about 12 years old now. It's got a stupid name. It's called the mini gastric bypass. There's nothing mini about it. It was called mini to sell the procedure because Rutledge, who came up with it, felt that having only one anastomosis makes it mini. It's actually very malabsorptive. The majority of patients who have this operation all have malabsorption and steatorrhea, and you have to be very careful about how you counsel them about it. And if you have pelvic floor problems, you will be left with incontinence. So you have to take those histories very carefully. However, the weight loss and metabolic change and reduction in comorbidities and mortality is as good, if not better, in our own cohort compared to the Rouen-Y. So there is some payoff between all of this. What does it look like in the operating theatre? So this lady, 200 kilos, strapped to the operating table, lots of safety issues, lots of pressure issues. To do the surgery laparoscopically, we have to be able to stand her up. There again, we have to be able to stand her up. She's 200 kilos and she is paralyzed because she's asleep. So there are lots of special bits of kit that we use in order to make it safe. Most important person in the room after the patient here is Alison. She's my anaesthetist. She used to work for the esophagogastric cancer surgeons, but they weren't very nice to her, so she came and worked with us because we're much nicer, okay? She is fantastic, and safety, safety, safety is what it's all about. We use 5 ports. This is actually a setup for a sleeve, you can see, because there's a 15mm port, but the rest of the ports are all 5mm. We have the benefit of an OR1 in our operating theatre and lots of space. We use special devices to seal and cut, which allows us virtually no blood loss. We have special devices to staple without any blood loss. This is specimen removal from the abdomen. That's what the stomach looks like once you fill it with water, and that is sent off to histology for most cases and sometimes for research as well, okay? Weight maintenance after bariatric surgery is really important, and if we don't speak to patients about it before, it doesn't work. And that, in my opinion, is where Tier 3 really helps. It educates the patients in preparation for surgery. Unfortunately, I don't think it really means that they avoid surgery. There are lots of reasons that for metabolic change. We've called these the slimmer effects. We published this in Nature Obesity some time ago. The reason I'm putting this up on a few other slides is not just because Trisha's here and she loves this stuff, but because the science behind this, and this is, it's a horrible thing to say as a surgeon, and forgive me, Trisha, but the science behind this has only been possible because of the surgical intervention that we have studied. And if we didn't study the surgical intervention, we wouldn't understand this stuff. And so that is a really important role of working in a department like ours. Francesco, as I alluded to earlier, is a forerunner in this, as much as it pains me to say, because he's from King's and we're supposed to be rivals, but he's a good guy. And he is a surgeon that made me think type 2 diabetes is a disease of the small intestine. Now, that's just such a fundamental change of the way I should think from when I was in medical school. That is the kind of proponent of bariatric surgery that we need. Is it cost effective? We're in an NHS, we're in a recession, we were governed by Boris, and we are broken, okay? So we need a cost-effective treatment. Is pharmacotherapy cost-effective? To a degree. Is lifestyle modification cost-effective? Nope. Is surgery cost-effective? Unfortunately, yes, and it's a surgeon saying it, but it is cost-effective. It has the right numbers. And actually, if you take one patient with type 2 diabetes who's picked up within a year of being obese and diabetic, and you operate on them, it will cost the taxpayer £7,500. But if you don't operate on them over their lifetime, it will cost you £250,000. So it is very cost effective. Loads and loads of studies done on cost effectiveness, okay? And they all say the same thing. Big paper came out, NEJM, shows that reduces all-cause mortality. Bariatric surgery as an intervention reduces all-cause mortality, has a survival benefit. So other than managing the patients that are referred to us for obesity from primary care, what's the role? Well, orthopods refer in because patients cannot have their knee, hip, and other surgery because the criteria are they're the wrong BMI. So does that mean that these patients should not be offered life-changing arthroplasty? course not. It means we need to help them as a team, but not just with bariatric surgery, in a collaboration to help them lose weight, get more mobile, have their surgery. It also means having a conversation with sensible orthopedic surgeons saying, look, you sent me someone with a BMI of 70, I am not going to get them to a BMI of 35. So if I get them to a BMI of 50, will you operate on them? Okay. And then you can help the patient. You can help the family. Abdominal wall reconstruction. Plastic surgeons and my general surgical colleagues, they do not want to fix hernias in big people. We're able to downstage them, have their surgery. Plastics, ENT, Fausto and Amy sent me patients from Endocrine. There was a cons patient who has to be positioned like this, and if they look like that, the surgery is somewhat challenging, isn't it, Fausto and Amy, right? So all of that retroperitoneal adiposity is really difficult to operate on, and they need to have effective weight loss quickly, and bariatric surgery does provide that. Other things for the role of surgery: research intervention, to study obesity, to understand the pathways, to allow a target for pharmacotherapy as a comparator to the other treatments out there, and as a truly clinical MDT intervention. Also allows me to publish loads, which is great. And I know the next session's on COVID. COVID didn't stop us. We continued to not just work clinically, but research during the pandemic. We used the data that we collected to see what difference does it make, and also how did it affect training. Bariatric surgery is challenging technically, but it is very trainable. It is standardizable. It allows transferable skills. So for example, at Imperial College, when I was first appointed, I was told I was an absolute lunatic and I was unsafe to try and treat this patient who's been stabbed here with laparoscopic surgery. And I was told that when the patient has a hole like this in their abdomen, that I should then make a hole like this in their abdomen to look inside and fix a hole like that. That is what I was told that I was mad about. But the reason that I was able to do that is because I had the transferable set of skills to operate on really big people with really difficult anatomy. So operating on a slim person with really easy anatomy is not really problematic. Nevertheless, it took 5.5 years and 500 patients and a reduction of 2,500 bed days to persuade our senior colleagues that not making massive holes in people is bad for them. Number two, laparoscopic skills are here to stay. Robotic skills, we have tried time and again. One day, at some point, they'll invent a robot that's good. But at the moment, the best robot that's sitting here, because we have looked at the timing. So until, robotic interfaces and things change, this is the way to teach surgeons of the future, and it's very, very important. So the future is pharmacotherapy. John is absolutely right. The future is endoscopy. Dev is absolutely right. There should be less primary bariatric surgery, but for those that need it, it should be available, because 1.5 million people would qualify for it at the moment. And if we tried to address that, we wouldn't have enough money in the public sector to treat cancer. And I know it sounds emotive when you go against cancer, because we're treating people who have allegedly put themselves into this position, but so have all the smokers. So forgive me for saying it. But that is the fight that we have every single week when there is a bed, okay? Will there be robotic assisted surgery? I'm sure there will. Again, I would throw a bit of caution to the wind here, because that is really driven by commerce and industry, but I think it will have a place. There are surgical neuromodulation devices. I'll show you some in a second, which we're involved in. It may have a role to play. Okay, I have put implantable devices into patients that change their satiety. I've put implantable devices into patients that allow them a better understanding of their HbA1c and their minute-to-minute glucose modulation. Okay, there are implantable devices that allow you to change vagal receptiveness. There are new tools out there, which I just don't understand why we cannot adopt into the NHS, that help behavioral change, because they prompt you through your smartphone, through your devices that we all use all the time. But most importantly, more combination therapies of all the things. And prevention would be ideal. I have 2 small children. I do not want them to be obese, which means I have to run around every Saturday and Sunday, A, as an Uber driver, and B, pretend that I'm still good at football. But it's really important as a continuum of family groups that we continue to educate our children and our children's families and friends that we need to live in a different way. So digital technologies, other new devices, okay, that are not surgical technically, but kind of surgical. Newer drugs that are coming out. I believe that Zapatide is going to be released in February, March of next year in America. Endoscopic therapies that really compare to surgery, and I think ESG is one of them. And I do think there is a massive place for ESG, and the UK has missed the trick. Robotics, if you see, look, to have robotic surgery, you actually have more ports than laparoscopic surgery, okay, at present. And as I said, collaboration. So what's the key to success? Good MDT, good pathways, safe processes, and work with excellent colleagues. You need high volume surgeons working in centers where this is what they do. Standardize your techniques and work in that way so you can train better and train more people. Collaborate, be transparent, share your data. In a funny kind of way, almost be proud of the mistakes because you can teach other people how to avoid them. Don't hide your mistakes. Share your good practices. Be open to change. It is very important. Every year I go to 1 or 2 different units just to see how things are done, to see what can we do better. And can we please put COVID behind us and just get on with things? Thank you very much.
A very nice round off to the obesity session. Do we have any questions?
Question up there.
We have quite a lot of our patients who are obese and diabetic. We find that they have lymphedema and also renal disease. Do you have any data on whether if you undertake bariatric surgery early enough that it can attenuate the progression of renal disease? And also, do you think lymphedema should be one of the criteria so that we can refer to bariatric surgeons for?
So let's talk about renal disease first. So at Imperial, we do have a renal part of the MDT. Harvinder Chahal, who's one of our endocrinologists, liaises very carefully with Andrew Frankel. And there is a special pathway for post-transplant, pre-transplant, on dialysis. We manage them in a slightly different way. They have their individual renal dietitians. We only operate on these patients because they're high risk on a Monday or a Wednesday. So the answer to that is yes. The data that the renal teams at King's and Imperial together have published, and Tricia might know the data better than me, but has shown that there is the ability to change some of that EGFR, but also for transplant patients, the surgeons want them to be smaller and thinner, so it's easier for them. Plus, there are a group of patients who have not gone on to dialysis as quickly as they would have because they've lost weight. And the second question, oh yeah, so I personally agree that lots of things should be criteria for bariatric surgery, but lymphedema and lipedema are often in conjunction, and they are not managed very well in most healthcare forums in the world. So with regards to lymphedema, yes, I work with the vascular surgeons and the plastic surgeons. There is a huge misdiagnosis of lymphedema where there is actually lipedema. And so those patients need very specialist therapy, and they're only available. NHS lipedema clinic in London is in St. George's Hospital. Currently, NICE, there is no criteria for lymphedema or lipedema needing bariatric surgery.
Sanjay, one last question from Alison Wren. How does mini bypass cause incontinence?
So mini bypass per se doesn't cause incontinence, but patients who have had 4 or 5 children and have a weak pelvic floor or have had a traumatic delivery, and who are less young, have weaker pelvic floors. If you give patients with weaker pelvic floors a procedure where they will have steatorrhea, more malabsorption, then they end up with incontinence problems. I would say about 1 in 20 cases, if you don't take the history correctly. If you take a pelvic floor, birth and colorectal history before you counsel these patients on these procedures, then I would say that risk is about 1 in 100.
Thank you. That's really useful. Okay, so we're just going to round off the session now and move on to the oral presentations.
Okay, can we have our first speaker? So while you're coming down, I would like everybody to join Menti, okay? Get your phones out if you're in the room, and if you're on Zoom, you can do the same thing. You can all see the Menti code. So this is just I know you know the answer, so just answer it. This is to make sure you join for the real question that we'll put to you shortly. Do you want to put this microphone on? I'll get to your question there. So if you could all get your phones out, menti.com 3208 9403. A minute to join. I can count. Yeah, 3208 9403. Okay, quite a spread there. The winners are pituitary, which is the right answer, but quite a lot of other things. So yeah, let's hear your talk. I'll just pop over to, I'll leave that in the background, and then when you get to your question, we'll ask.
Working? Yes.
Yeah, okay.
Thank you. Good morning. I'm Einish. I'm one of the endocrine FY1s at St. Mary's Hospital. I'd like to take this opportunity to discuss quite a fascinating case that was managed over the last year and a half. So our story begins with a 53-year-old woman who was found to have dyslipidemia with a total cholesterol of 9.4. He was started on atorvastatin and referred to the lip. In the interim month, awaiting a report, he was diagnosed with type 2 diabetes and hypertension, notably with no family history of either. Then in the liver clinic, he was found to have abnormal liver functions, leading to cessation of a statin, as well as skin darkening. After the statin was held, her liver function improved. We had an ultrasound scan of the neck that showed some carotid interval thickening, as well as a CT coronary angiogram that showed no coronary plaques. I'd like to take a moment to present her blood work from March earlier this year, including her lipid profile. As you can see, she was normocolemic and her HbA1c was 57. However, leading up to this blood test, she also developed some facial swelling and proximal myopathy, and these Cushingoid features prompted an overnight dexamethasone suppression test. The morning cortisol, after which was 752. She was promptly referred, where she underwent four lab tests. The first were 2 24-hour urine-free cortisols. The collections from well above the upper reference limit of 270. Also had a low-dose dexamethasone suppression test. The cortisols were 606 and 642 at baseline and at 48 hours, respectively. And this all painted a picture of ACTH-dependent Cushing's syndrome. We had a couple of MRIs. The pituitary MRI showed enlargement of the left lateral aspect of the gland, as well as left-sided deviation of the infundibulum. And the adrenal scan showed bilaterally bulky adrenal glands. As she was quite symptomatic, she was commenced on ketoconazole, 100 milligrams twice daily. And we noticed some improvement in the symptoms. Her weakness and appetite improved, hypertensive and glycemic was also more manageable. He was also started Oxfam. Following this, she was sent for an IPSS, and that stands for an inferior petrosal sampling procedure, and that's a localization of the pH salts. The results from which are illustrated. It's quite a busy slide, so highlight the ACTA, the prolactin, both centrally and peripherally, at baseline, 10-minute RH registration. And if the Menti question work here,
It will.
hopefully
Yeah, so you can do that. Yeah, so they can all see the question on their phones.
So keeping in mind the pituitary MRI that showed enlargement of the left lateral aspect, these results highlighted here. The question is, what would you do next?
You have that vote.
Let me know
I'll just-
when they ask.
Okay, so there's 13 people voted so far. So options are repeat IPSS, offer pituitary surgery, the gallium scan, or on the basis of this IPSS. I think we Okay, so it looks like 8 people want to repeat the IPSS, 8 want to offer surgery, and there's quite a lot who want to do 2 different scans. But tell us what.
So that was the question. So before I move on to what we did next, results. So the ACTH central to peripheral ratio here, both at baseline and at 10 minutes. But if it were much higher, of the access. And so these results topic of Cushing syndrome. And you may recall the patient had a CT coronary angiogram earlier, but for pathology, and quite fortuitously on retrospective review, we identified an 8 millimeter carcinoid-looking nodule, the lower lingula of the left lung. And this was further interrogated, identify and localize. We actually went for a gallium-68 dotatate scan. Scans the images there. As you can see, there's an 8 millimeter tracer avid nodule in the inferior lingula of the left lung. The MDT elected to surgically treat this with a left VAP lingulectomy and lymphadenectomy. The nodule wasn't biopsy, but it was section. And once resected, it was histologically confirmed to be carcinoid. Up there. Cortisol, following morning, 5. He was promptly commenced on a regime of Essalone, cleanly followed up. But I think quite nicely. So the very first result is the first failure to suppress of following the overnight Jack-Smith suppression test. And we've got the further failure to suppress results with a low-dose PST. And we can see a reduction in the following commencement of ketoconazole. Then again, it's up titration. And of course, we've got the drastic reduction in cortisol after the nodule is affected. The latest cortisol value that we have is 107. That's hopefully in recovering. Post-operative recovery was uncomplicated. Noted a reduction in a Cushingoid feature, blood pressure and blood sugar. To conclude, ACTH-dependent Cushing syndrome accounts for 80 to 85% of all Cushing syndrome cases. About 15 to 20% of those cases are due to non-pituitary topic Cushing syndrome. Localization can be difficult. Gallium-68 dotatate scans have been highly sensitive. However, localization is still difficult, and whole MDT is required to ensure strong. Thank you all very much.
Thank you. That's a very elegant presentation and a really nice case. You've just made a surreptitious advert for always looking at the scan and not just looking at the report. And I really appreciate that. Can you go back
To the which scan?
to that CT chest? Because I mean, I'm a real amateur here, so forgive me if I'm out of place, but I can see about 20 white dots. And one of them's got a green arrow next to it. Am I alone in this? You know, we all nod wisely, but can you tell me, or can somebody tell me why that one's special?
I'd hope someone can. I'll be honest.
I think
this was the location because the radiologist very kindly put a little line there.
That's not natural, I can see that.
So I will say that the radiologist did spot it before the gallium scan. Exactly as we said, when we saw the IFS was clearly ectopic, he went back and looked at it, and he rang me up and he said, in fact, you can see many cuts, of course. We're looking at one cut, and that's not fair. But when you look at several cuts, he said the distribution of it and the way its blood flow because they had done some contrast, the way the flow through it makes it look like a carcinoid tumor, and that was
at least not like an vessel.
Absolutely, Kareem. It's Stephen here. Yes, I think that's the point. You're quite right that looking at the scan, there just looks to be 20 dots. But the point is, most of blood looking at blood flow, but the blood stayed in that. And so, as you say, it's the blood flow that suggests that that's a solid lesion rather than just a vessel. And they also look at the amount of uptake as well, which is a number that we don't have here.
Thank you. There's a question from Professor Alt. We'll just get the microphone up here.
Thanks, Karim. Yes, thanks so much for a very nice case presentation. But obviously, I need to ask, why did you do an MRI adrenals, given that it was an ACTH-dependent Cushing?
So sorry.
I'm afraid that's me. I'm sorry that we asked for images early on because of the way that we get the tests, and you might have to wait some weeks. I agree. In retrospect, it wasn't needed, but I felt this was certainly Cushing syndrome, but I didn't have the ACTHs. I asked for that early in the proceeding. It relates to how quickly one can obtain tests in the NHS.
Thank you. Go ahead.
Just one more then. Can you go back to the MRI pituitary? Because I'm a real believer in looking at the images because it helps you remember the patient and you can really get this. So it's very tempting, isn't it? When you see that on the left, you think, oh, well, there we are, you know. The stalk's deviated the wrong way, actually, for textbook. But that's just normal? Are you saying that's a normal pituitary gland? That's fine, no problem with that?
Yeah, it's normal. And I think...
It's hard to take your eyes off it, though, isn't it, when you start?
We put that there, I mean, it's truthful, but also slightly to mislead everyone. to make them think there could be a small adenoma.
Well, she misled you, so that's all right.
Yeah. But
Make that a mystery.
Yeah.
Yep. Thank you.
Okay, there's one other question to the back. I'm going to run to the back, okay, because otherwise the Zoom people can't hear you. No, they can't hear you on Zoom. So hey, here you go.
We had two options for label scanning, and you went with gallium. I know that the methionine PET-CT has been used by other groups in the past. Do you have a comparison as to why one is better than the other?
So we were actually only talking about it yesterday, and yeah, yesterday was the first time I've really had any learning about it. But from my understanding, so methionine PET-CT scans have only really been used to characterize pituitary